Final project submission for the course 3, Human Factors in AI. The ML project that I've chosen to describe here is the same one from course 2, which is really automate the surgical bed balancing process, optimizing the allocation of beds for scheduled surgeries and demand from daily emergency room or ER cases. The problem is that the current process for surgical bed balancing is manual and reactive, resulting in hallway medicine, delays in clearing elective surgery backlog, and limiting the ability to deploy innovative care models that reduce ALC. The target user is the bedflow manager. The process today is the one shown below. It's a very high level basic task analysis, which really runs from daily morning huddles to review bed allocation by different surgical units, what discharges are planned for the day or the step downs to different types of beds, identify patients on the wait list who need to be prioritized to fill the empty beds, and then what beds might be needed for emergency room cases on an urgent basis. And a lot of this process is manual, basically negotiation between different department heads and the bedflow managers, and relies on manual synthesis of fragmented data, which builds in uncertainty with discharges and a high cognitive load on the bedflow manager. And this results in multiple huddles throughout the day to look at what beds are becoming empty or need to be emptied with patient discharges, and how how the bed needs get balanced between patients on the wait list and the ER cases. So the task analysis really here, as I said, tells us this is manual and reactive process, which introduces inefficiencies, especially in a high cost of care setting, which is the acute care hospital. The allocation can be predicted using data, our machine learning algorithm for a 24 to 72 hour period, and also week-long forecasts, allowing surgical units to manage discharges, wait lists, and bed allocation to ER patients, along with surgical staffing schedule, which improves staff morale and reduces their burnout as well. The huddles would become highly efficient as they would focus on validating the model's predictions and handling the real-time alerts and will minimize the guesswork and manual coordination required. The model will also help predict potential allocations during surge season based on historical data. And given the proactive management of beds, the surgical bedflow manager will be able to manage discharges and number of people on the wait list who need to be assigned for surgery. As the guesswork and manual administrative process will be removed from the task flow, the user or the bedflow manager will be able to efficiently manage their operational task and improve the health outcomes of the patients, and improve access to the surgical services required. Now, the simplified data-driven task will also make the decision-making transparent and visible across the surgical and ER departments, reducing the amount of coordination required and burden of negotiating bed allocations. In terms of user design, the ML-powered surgical bed allocation dashboard can be used to drive the daily morning huddles, to review models' bed allocation and perform manual overrides where necessary, and review the relevant staffing schedules. The real-time review of alerts and coordination of decision-making with various departments to assign and discharge beds. The user inputs will be pretty much throughout the process in terms of first approving before the discharge process of a patient begins, because you don't want a machine learning algorithm making those decisions. And this is where the human in the loop comes in. Or schedule adjustments that need to be made, bed availability updates, and manual overrides, as we talked about before, and the staffing constraints. Now, in terms of feedback loops, it should be both implicit and explicit. The user overrides should be captured and analyzed. The reasons for override should be identified by engaging with the user to improve the future model training, and continuous learning from prediction errors and decision acceptance rates. In terms of model transparency, given the nature of the industry, the model needs to be highly transparent. It needs to provide clear explanation of bed allocations, why a patient was marked for discharge, why a certain number of beds are allocated for ER use, especially if the model gets integrated with an electronic health record. The notes from nurses and physicians could be used to make the model more accurate in terms of discharge predictions. And the clear explainability of the algorithm will be essential in model transparency, especially as much as also avoiding technical complexity, because the users vary from clinical to operational users. In terms of communicating uncertainty, confidence, and prediction intervals of key values is essential. Also, potentially providing a range of beds that can be allocated. So, for example, saying 8 to 10 beds will be available for allocation based on potential discharges rather than saying 8 beds or 10 beds. And similarly, predicting a range for your beds that might need to be allocated for the day based on predictions. In terms of privacy concerns, because personal health information will be used in terms of patient admission, discharge data, surgical case details, and demographics, have to be careful about unauthorized access to PHI, data breaches, or re-identification in analytics. The proposed mitigations here really are to de-identify where possible for model training, role-based access control, encrypting the data, audit logs for access, and data minimization, which basically means use only the data that is necessary. The laws that apply here are the Personal Health Information Protection Act of Ontario and any hospital or Ministry of Health privacy and data protection policies that are necessary for the model to abide by. In terms of ethical considerations, there are a few potential biases around historical bias, like how past decisions on discharges were made, algorithm bias in terms of favoring shorter length of stay cases, which really is the efficiency bias that disadvantages complex patients. Representation bias, patient census data might not be representative of the population data, which can cause errors in predicting ER demand. Data quality bias, which really is inaccurate length of stay cataloging or discharge predictions for certain patient groups, especially those who are elderly or complex care. And then automation or deployment bias, where ineffective human in the loop decision making or over trust in the model generated decisions rather than the override that the user should be able to make based on their experience and the patient reality of the beds. In terms of ethical AI, fairness, model recommendations across surgical specialties and patient complexity levels would need to be monitored. Ensure the model does not systematically delay certain procedures or favor low complexity cases, as we talked about. In terms of accountability, a human in the loop, the bedful manager should be the one making the final decisions and consult with the necessary surgical teams. All recommendations should be logged in terms of inputs, outputs, and overrides. Regular performance reviews in terms of prediction accuracy, impact on cancellations, and then wait times. Transparency, as I explained before, clear explanation of the recommendation, the key drivers of prediction to uncertainty and confidence levels, and maintain documentation. And that brings us to the end of the summary of how I approached this project for the Human Factors in AI course.